I'm very happy to announce Dr. Pearl Grimes will be joining us for the live discussion as well. Dr. Grimes is a founder and director of Vitiligo and Pigmentation Institute of Southern California and the Grimes Center for Medical and Aesthetic Dermatology. She is a pioneer and a leading international authority on vitiligo and pigmentary disorders. Dr. Grimes is a clinical professor of dermatology at David Geffen School of Medicine, University of California, Los Angeles. She has authored more than 150 professional articles, abstracts, and 2 textbooks. Dr. Grimes holds numerous achievements in dermatology. She has been recognized by her peers with prestigious Dermatology Foundation, Practitioner of the Year Award, and the Women's Dermatologic Society's Mentor of the Year Award, and the American Society of Dermatologic Surgery President's Award in 2006. In 2016, she was recognized with an American Skin Association Research Achievement Award. She was also awarded the prestigious 2017 Arnold P. Gold Foundation Humanism in Medicine Award and the 2017 Everett C. Fox MD Memorial Award and Lectureship Award. She has many other awards. She is also an active member of multiple professional organizations, including the American Academy of Dermatology, American Society of Dermatologic Surgery, the American Dermatological Association, Society of Investigative Dermatology, the Dermatology Foundation, International Federation of Pigment Cell Societies, and Dr. Grimes was the president of Women's Dermatologic Society for 2018 and 2019.
I am so honored to speak today on the changing landscape. Hi, everybody. It's Pearl Grimes. I wish I could be with you in Bangalore. I am so honored to speak today on the changing landscape of childhood vitiligo. And certainly from a historical perspective, I continue to treat so many children here at the Institute with vitiligo. These are my disclosures, and I have no conflicts today in giving this lecture beyond having been involved in clinical trials and vitiligo research for the duration of my academic career. So when we think about the changing landscape of childhood vitiligo, what has happened? We've increased our knowledge regarding the burden of disease in patients and in their families. I think we're increasing our knowledge of the relationship or the frequency of comorbid autoimmune diseases in childhood vitiligo. There's exciting and emerging data on the pathogenesis of segmental vitiligo, and I'd like to share recent data on ruxolitinib in adolescents with the disease. So certainly from a historical perspective, when we think of the epidemiology of childhood disease and we look at the frequency, the median age of onset for most studies is between 5 and 10 years, 30 to 35. It encompasses 30 to 35% of all patients with vitiligo. So what tends to be unique to this population? Greater disease severity has been reported, progressive disease, increased numbers of affected family of relatives. Some studies suggest that there is an increased incidence of female gender. Others do not show that increase. Halo nevi are common. Family histories of premature graying. Certainly segmental vitiligo is increased, and studies suggest that there may well be a superior response to repigmentation approaches. So let's talk about the expanding knowledge of the burden of disease in the pediatric population. So we now know that vitiligo has a substantial impact on quality of life for parents and children with this emotionally devastating disorder. And we know also that the impact on quality of life can vary and be more severe in some cultures, races, and ethnicities compared to others. And some of the concerns, certainly for parents, will it stabilize? Will it repigment in my child? Will it progress? And there's an enormous amount of shame and guilt and anxiety regarding the unknown. So this is a recent study. It is a systematic review and meta-analysis of 429 subjects. This was a global study, 429 subjects, 17 studies. And the authors looked at the impact in children, and there were 3 studies looking at the impact in parents, caregivers. And what was unique, in the children and adolescents, they had a much higher incidence of embarrassment related to their disease, teasing, and bullying. And the predictors of that impact on quality of life included adolescent age, severity, body surface area affected, facial involvement. And in parents, parents had a moderate decrease in quality of life, and there was an increase in the prevalence of depression and anxiety. So I think one of the messages here, you can see the impact of quality of life decreasing as kids get older. So I think one of the key messages here is we need to be more aggressive and target therapeutic intervention in these kids at a much earlier age. This is a recent study of 30 children, and the control group included 30 controls, and they looked at children and adolescents. And here they assessed emotional dysregulation, attention deficit. 90% of the patients had at least one psychiatric diagnosis compared to the controls. There was an increase in ADHD, and also anxiety disorders and depression was increased. So another take-home message beyond therapeutic intervention is, I think we really have to have our antennas up during the initial consultation, as well as the follow-up visit, to really be sensitized to emotional issues in the children as well as in the parents. And we must be ready immediately to refer patients for counseling and giving them that global support in managing this condition. Now, let's flip gears a little bit. I mentioned we were going to talk about comorbid autoimmune diseases. So we're getting substantial new data on comorbid autoimmune diseases in the pediatric population. This was probably the largest study looking at comorbid autoimmune diseases. In this study, they looked at childhood onset vitiligo in 38,500 plus patients, 77,000 controls. There was a statistically significant increase in a number of comorbid diseases, including the most common, atopic dermatitis, which is a Th2 rather than Th1, and we're going to tease this out a little bit more. Increase in thyroid disorders, Hashimoto's thyroiditis, Graves' disease, type 1 diabetes, alopecia areata, rheumatoid arthritis. So, significant relationship in an increase in autoimmune diseases in this very large childhood onset vitiligo population. Now, here, these investigators in this systematic review and meta-analysis did the opposite. They looked at the frequency of vitiligo in a very large group of patients with atopic dermatitis, 7 studies, over 1 million patients. So this was a meta-analysis, case control, cross-sectional studies, and it showed a significant association of atopic dermatitis with vitiligo. So when you just look at atopic dermatitis, those patients have an increase in vitiligo, and when they looked at the sub-analysis, in looking at adult AD patients and childhood atopic dermatitis, they still showed the same relationship. So this is interesting. Again, there are a couple of other studies I want to quickly cite. In our ruxolitinib data, we looked at patients who had a Th2 response versus a Th1, and those patients who had a Th2 response, which we see in atopic dermatitis, actually had better repigmentation. Another recent study looking at vitiligo IgE levels, those patients had less autoimmunity. So I think this area and the relationship between atopic dermatitis and vitiligo, given the differences in immune responses, this is ripe for additional studies, given the fact that it may give us substantial insight regarding therapeutic intervention and how we approach these patients. So to continue to peel the onion on comorbid autoimmune diseases, what about the relationship between thyroid disease and children with vitiligo, given that in general, if we remove atopic dermatitis, certainly thyroid disease is the most common in most studies, associated autoimmune disease that we see in children as well as adults. So while the frequency may be less than what we see, I've cited 5 studies here, beginning with our work around 2000, showing clearly that if you perform these studies, children with vitiligo, you are able to pick up a relationship in thyroid disease, as well as seeing an increase in thyroid peroxidase, even thyroglobulin antibodies. In one of the studies from OFSAR, subclinical hypothyroidism was present in 16% of the subjects. In the Martin study, hypothyroidism, 7%, hyperthyroidism, 0.5%. So I think it's very important that we look at how we work up these patients, and we're going to come back to this in a minute. But before I do, I want to also comment on circulating vitamin D levels in vitiligo. Now, why is this important? Vitamin D is not a vitamin, it's a hormone, and it is such a major important player in modulating the innate immune system as well as the adaptive immune system, key in the pathogenesis of vitiligo. And vitamin D is also a major antioxidant, given its impact in upregulating the NRF-R pathway. So the study that I cite above is a meta-analysis of 31 studies. And in this 31 studies of vitiligo patients, there was a significant decrease in vitamin D levels in vitiligo patients compared to controls. The levels were even lower in indoor urban workers. So if we specifically look at, I wanted to cite at least one study in the pediatric population, and there are others. In this study, they looked at 114 patients, 100 controls, and here the investigators reported a significant increase in vitamin D deficiency in the cohort of patients versus controls. And very interestingly, the older group, the 4 through 7s, the 8 through 12s, had a lower level, suggesting that maybe in that earlier group there may have been greater outdoor exposure. But again, this supports the concept of vitamin D deficiency in both the pediatric population and adults with vitiligo. So I think correcting this is very important, given the impact of vitamin D on the innate and the adaptive immune responses. So again, if we think about how we want to process comorbid autoimmune diseases, I think it's important in that initial consultation that we do a detailed screening in our patients. And I think as we do in our adult population, I think laboratory studies are important. Here I list the tests that we do at the Institute, CBC, metabolic panel, thyroid panel. We do thyroid antibodies and ANA and a vitamin D level. But I think the bare minimum that you should do is at least you should order a thyroid panel and thyroid peroxidase antibodies, because those antibodies, even when the thyroid function tests are normal, can portend that that patient will develop thyroid disease down the road. Now I want to switch gears and talk about emerging, exciting data on where we stand regarding segmental vitiligo. So again, from a general perspective, studies suggest that there's an increased frequency in childhood, anywhere from 5 to 7% of all cases. Most studies suggest that these patients stabilize in 1 to 2 years, more often 1 year. That's my experience. Multiple theories have been proposed. The neural theory, we thought that segmental was very different from non-segmental vitiligo. Somatic mosaicism has been proposed. Studies suggest it's less responsive to medical treatment given the leukotrichia. These images here are from Van Giel's study showing, this is a study from 2010 showing an influx of CD8 lymphocytes migrating into the involved skin of patients with vitiligo. So this is one of the earlier studies suggesting that maybe the immune system is involved here as well. This is a seminal study published in 1996 by Han's group from Korea. They looked at the age of onset, and this is generally what we see. Most patients, in my experience, who get segmental get it before age 10. The overwhelming majority get it by age 19. However, I will mention that we're seeing a recent trend where we're seeing segmental in older patients here at the Institute, and certainly the common nerve distributions that are affected are the trigeminal and cervical distributions. So a newer insight in segmental, this is a study from Zhu's group looking at 379 patients, and they stratified these 379 patients into 3 groups. The segmental group encompassed 33%. Then they had a group, 34%, with mild to moderate non-segmental disease. They had less than 10% involvement. The third group had greater than 10% body surface area, and so this was considered severe. So segmental, mild to moderate disease, and severe disease. So what was the commonality? The authors reported that the disease activity, progression, serum cytokine profile, and the infiltrating lymphocytes had a similar profile in segmental and mild non-segmental vitiligo. And here, if we look at CXCL10 levels, while elevated in all groups compared to controls, the segmental group and the patients with mild to moderate degrees had comparable levels. Progression was comparable in the segmental and the mild moderate disease. So here I think we're clearly seeing that this further supports the concept of immunologic parameters being involved in the pathogenesis of segmental vitiligo. Now, this is probably my favorite study of the year. And why is it my favorite study of the year? Because we were the first in the world many years ago to propose a viral pathogenesis for vitiligo. So this is Dr. Gauthier's work, and what they did, they looked at a group of segmental vitiligo patients and reported varicella zoster virus in the actively spreading segmental vitiligo skin, which is so exciting. So they looked at 40 segmental vitiligo samples, 3 herpes zoster. They had 10 patients with generalized vitiligo. And here, if you look at, and then they looked at the similarities in what was happening in melanocyte, cell and nuclear fusion, syncytia, and even varicella zoster antigen. So what they reported, there was an increase in nuclear fusion in epidermal cells with recent segmental vitiligo. They found syncytia formation. It was associated with long-lasting segmental vitiligo. And these are changes that you typically see in herpes zoster. They detected a significant increase in varicella zoster antigen, and mature virions were identified in 3 of 3 recent samples. So the findings from this study support a viral hypothesis for segmental vitiligo. I think this work needs to be substantiated by other investigators, but I will cite there are 2 papers in the literature suggesting that if you treat segmental patients with antivirals, these 2 studies showed significant repigmentation. So I want to finish up now in talking about and just reviewing therapeutic interventions for childhood vitiligo. Really, the concept is the same as we use for adults. Stabilization, repigmentation, being able to maintain it. We've got to address the JAK-STAT, chemokine, interferon gamma pathway as shown here. So we've got to put out this fire that's raging and destroying melanocytes if we're going to be able to effectively take the patient from here to here. So we've got to put out the fire. We've got to decrease oxidative stress. We've got to decrease that aberrant immune response and increase melanocyte degeneration. So what are the tools in the toolbox? For stabilization, we have oral corticosteroids, narrowband UVB phototherapy. I'm a major vitamin supplement person given the oxidative stress story. All my patients are on vitamin D. Repigmentation, certainly topical corticosteroids, the calcineurin inhibitors, phototherapy, autologous grafting, and we're going to talk about some emerging JAK data in adolescents. So stabilization, this is a study, an older study, but I think it's important to cite 343 children that were treated with oral mini pulse therapy for stabilization and repigmentation in this study. Children were treated for six months. 90% had complete repigmentation, 66% had good to excellent. However, there were side effects. In our experience, I don't think you have to treat as long. I think you can clearly go less than 6 weeks. Sometimes I treat for 2 weeks with daily steroids, and the kids do well and they stabilize. So topical therapies, mainstay for the current time for kids, topical corticosteroids, calcineurin, first-line therapy for patients with limited disease, best results on the face and the neck, comparable efficacy. However, with the steroids, we have to be concerned about atrophy, acne, telangiectasias. We don't have to be concerned about that with the calcineurin inhibitors, and they are so great for long-term therapy and maintenance. And this is a systematic review meta-analysis comparing the 13 studies, 509 patients. And here, if you look at this data, comparing the 2, looking at greater than 50% repigmentation, 75% repigmentation in children, clearly this data is comparable. So they each have their advantages, but the calcineurin inhibitor is great for long-term maintenance. And this is another study looking at the calcineurin inhibitors in adults and children. In this study of 1,499 patients, there were 177 children. And very interestingly, if you look at the overall data and then we pull out the data for children, you can see for the greater than 75% group, 50% group, clearly the kids do better than adults, and this is what has been reported in the literature, enhanced repigmentation in the pediatric population versus adults. If we look at narrowband UVB, which is clearly the therapy of choice for children with more generalized involvement, it's an amazing tool for both stabilization and repigmentation. And if you look at these studies, greater than 75% repigmentation. In New's original study, 53%, here 75%. So I think these are higher than what we see in many of the adult studies, again, suggesting overall enhanced efficacy. This is a study looking at the excimer laser in a pediatric population, excimer laser monotherapy versus excimer laser in combination with tacrolimus, pimecrolimus, or halometazone. And again, better results with combination therapy, and this is what is suggested in most studies, that combination therapy when you use the excimer laser is superior to monotherapy. So monotherapy here, 57% but we increased to in the 70s as high as 84% with the halometosome group. So if you're going to do the excimer laser in adults or children, combination transcends monotherapy. Now, I want to finish up with ruxolitinib. You're all aware of the ruxolitinib data overall. It was approved during the summer in the United States. So I want to share data where we pulled out the data on adolescents. You're familiar with the protocol, 1.5% ruxolitinib twice a day for 6 months, vehicle twice a day. Everyone after 24 weeks got ruxolitinib. And this is the interesting data in the adolescent population. So this is overall. At 24 weeks, 30% had greater than 75, increased to 50% at 52 weeks. If we look at the data in the 72 adolescents that we had, here this is the active group, 32% at 24 weeks, slightly higher than the 30 here. If we look at 52 weeks, 48, slightly less. And then this is the data for adults, 30% versus 32, 50 here at 52 weeks. Now, let's go to the total body data. This is really interesting. Here you've got 21 at 24 weeks. In the children, it was 26%, but if we go up to 52 weeks, it was 60%, slightly higher for the pediatric population versus the adults, 49. So I think there is a trend here suggesting that maybe kids do better. And it's amazing that we see this on the body rather than the face. So I think that clearly this response is worthy of additional investigation. So what have I talked about? The landscape has changed. We're seeing substantial new data on the burden of disease, the increased incidence of comorbid autoimmune diseases in the pediatric population, exciting data on segmental vitiligo, and data on ruxolitinib. So it's wonderful.
We have vitiligo.
I live with it every day.
Neither of us have spoken to a dermatologist in a while.
You're not alone. 2 to 3 million people in the United States have vitiligo, like you. I wonder if they also worry if it's going to spread.
Or what people will think.
Many people may not realize that vitiligo is more than cosmetic. It's an autoimmune condition. Your immune system attacks and destroys the pigment-producing cells in the skin, causing the white patches to appear. You know, some days I'm really proud of these patches. Other days,
I wish I had different skin. But what can we do?
speak with the dermatologist. We've increased our understanding of vitiligo. So a strong relationship with your dermatologist allows you to learn more. And it all starts with you making that appointment.
I'll end by saying vitiligo it's my passion. I've been such a part of this journey. And so the landscape of childhood vitiligo and adult vitiligo for that matter it's changing. And I think that this is an amazing time for we are truly on the cusp of exciting discoveries which will create substantial new paradigm shifts in our workup and our treatment for patients with this psychologically devastating disease. So, wish I was there with you, and I so thank you for your time and your attention. Bye. Hi, everybody.
Yeah. Is she online? Hi, Pearl. Can you hear me?
Yes, can you hear me?
Yeah. Thank you very much for an excellent talk on pediatric vitiligo. So, yes, there is a.
I wish I was there, and I'm up at 2-something in the morning to join you.
Yeah, so we are also missing you here. Yes, Stephen. Yeah, sure. The mic, please. So there is a question.
Dr. Grimes, can you hear me?
Yes, I can.
Okay, hi, it's Steve Taylor from Be Strong. I wished you were here in person.
Hi, Steve. I wish I was there as well.
So, I heard your presentation, outstanding, but at the same time, it scared me because I was thinking, when I was growing up as a kid, yeah, you would get sick, you would get a scraped knees, but you don't get disease. And when I heard the statistics and all the stacking of other diseases that you mentioned, I'm like, are you, from your experience, are you seeing a spike in kids getting these vitiligos with your experience? I mean, what's going on here with the kids?
You know, this is how I would respond to this. There may be some increase in childhood vitiligo, but we're seeing a bimodal increase. In addition to seeing an increase in children, we're also seeing an increase in adults at a later age. And there was a recent, very fascinating study in the literature that supported these very observations. I think for me, the take-home message is, let's say that there is an increase in children. What I would like to convey to the audience today is, given the increase, I think from a historical perspective, we've been a little bit remiss in how we work up kids. We've assumed that autoimmune diseases are less in the pediatric population. But again, if you really tease out the data, and you know, at this point at the Institute, I think we've seen thousands of kids. I think we have to be vigilant in looking for associated comorbid illnesses in kids, just as we look for these conditions in adults. So fear is fear, but knowledge is greater than fear. So I think the take-home message for me is, how do we approach this population?
Well, we appreciate all you do for our kids because they're our future. And we want them to go into the future with less handicaps as possible. My second comment, dealing with supplements, when you talked about the B's, the D's, and the other supplements and everything, as you may know, FDA, and I brought this up from a previous discussion on supplements, is not regulated. And people are out there taking these supplements, trying to, on these recommended supplements, but it's not regulated. There are a lot of placebos out there. So when you mention they're lacking in supplements, are there any provisions to say, take this particular brand? Because I remember you telling me one time in Atlanta, Georgia, about sunscreening, and you said, and I quote, make sure it has titanium in it because it doesn't get absorbed in the skin. Is there any way we can give them directions on, say, take this brand of supplements because it works?
Great question. And this is how, so I'm going to respond to that by first framing it. So I do believe in supplements for vitiligo, but clearly there's the good, the bad, and the ugly out there regarding the world of supplements. I have patients who come in and they're on, if I look at what parents are giving their kids, what I see in my adults, they're patients on 15 or 20 supplements. And we literally we make a list of all of these in the initial consultation so that I can appropriately counsel patients. So while I'm an advocate, I do understand the underbelly. So how do I deal with it? My first conversation with patients is, come on, let's clean this up and get you on something that's hopefully appropriate and beneficial for your condition. Of all the supplements, given what we know about vitiligo, I think having that patient have a healthy vitamin D level is the most important. So if I'm only going to recommend one supplement, I recommend vitamin D, and I adjudicate dosing based on their levels. That's number one. Number two, I do have supplement brands that I respect and I recommend, and we typically, and obviously I can't call those brands out right now, but I go with very reputable brands, and I recommend, I share with my patients. All supplements are not equal. We recommend a multivitamin, a reputable multivitamin for kids. I recommend fish oil. Sometimes I recommend a probiotic. Those are my standard. But again, what is the most important? I think vitamin D. If someone tied my hands and said, Pearl, you can only have one, it would be vitamin D. Given its role as in regulating the immune response, T regulatory cells, and as I mentioned, it also upregulates the most powerful oxidative stress pathway.
Thank you. So this another question from Thierry.
Hi, Pearl. This is Thierry Passeron. We miss you.
I wish I was there.
Me too. I fully agree with your comment on supplements, and I do think that some of them are very interesting. The problem is that we have everything in the market, and not all of them are the same for sure. And I would praise for making a real study with double-blind placebo study, even with supplement, because this is the only way to know exactly if they are effective and what type of supplement is effective. I'm like St. Thomas. I'm only prescribing something that has been demonstrated. And so I really think that we need, as physicians, to work together and to force the companies to make some real studies, because supplements is a cost also for the patients, and I'm not comfortable to prescribe a supplement that has not been proved to be efficient. I don't know, what is your opinion about that?
I agree with everything that you're saying. So let's go back to what I'm recommending. I'm recommending vitamin. Okay, we talked about vitamin D. So we know that there are multiple studies in the literature looking at vitamin D levels and deficiencies in adults and children. I don't think you can go wrong with a safe, reputable multivitamin. There's Caroline LaPoule's work on the gut microbiome, and we were actually we were very interested in the gut microbiome and the use of probiotics even before Caroline's work. So we're selective in what we use, but I agree with you, Terry. I think we really should. Patients are, we cannot control patients and their approach using integrative or alternative medicine. And so I do believe in components of this world. So I think it's up to us to keep patients out of the weeds and give them some guidance. I also think it's important for us as clinicians to get, when that patient comes in for the initial consultation, we need to find out what they're taking, because the other underbelly of this world that I see is patients take things that upregulate the immune system. I'll give you an example. Supplements like astragalus or even ashwagandha can sometimes upregulate, and that's not what we want. So as clinicians, we need to tease it out in the initial consultation to get a sense of what that patient is taking, what the impact may be on their immune system, and give them appropriate guidance. And secondly, I agree with you again 100% that it would be amazing to be able to do a national, international study in looking at the impact of supplements in the disease.
Yes, Dr. Ramani.
Hey, Pearl, this is Amit. You look just as impeccable at 2 in the morning as 2 in the afternoon. We wish you were here too, but yeah, so theory is doubting Thomas. I'm doubting Thomas number 2. So I'm just going to ask you, do you ever give ginkgo to kids, and what dose do you give? I know Davinder did like 40 milligrams 3 times a day, I believe, in his study. Is that right, Davinder? Was it 40 milligrams 3 times a day?
Yeah.
Yeah, and do you ever give that, Pearl?
You know what? I'm aware of the ginkgo data. If you said, Pearl, do you use ginkgo a lot? My answer is no, but I will tell you when I will use ginkgo. If you tease out all the mechanisms of ginkgo, it has anti-anxiety and antidepressant properties. Patients probably sleep better on ginkgo. So if you go back, Amit, to how I started this talk and my comments on burden of disease, anxiety, depression, if I have a patient where I think that this is an issue with kids, then those are the kids where I'm probably more likely to consider using ginkgo.
Thank you.
Yeah. Yes, please go
Dr.
ahead.
Grimes, I'm Dr. Chao Yi-Eng from Taiwan. So my question is, you have mentioned about using the systemic steroids for kids up to 6 months. So my question is, would you consider using steroids for refractory pediatrics patients? Because it might affect the growth of the kids, and in the clinical practice, sometimes when we stop the steroids, the vitiligo tends to come back, and especially in very young patients. I got patients like 1 or 2 years old with non-segmental vitiligo. It's spreading quickly, and if you're giving steroids, there's always a concern that it's going to cause growth, slowing the growth and developments. And yeah, so what would you recommend for other, because there's little trials or studies for non-steroids or steroid-sparing immunosuppressants. Would you use like cyclosporine, or what else can we do? Because yeah, the phototherapy, it's difficult for the child as well.
Well, first of all, I cited that study, but I also commented that in my own experience, I never keep patients on steroids for up to 6 months. I don't do that. And I made the comment after I cited that study. My comment was, at the Institute, we use systemic steroids for stabilization for a much shorter period of time. I will do 2 weeks. I will do up to 6 weeks for older kids, but my typical steroid dose in the pediatric population is 2 weeks. And I do it because I don't want to deal with long-term steroid complications. I think narrowband UVB is an amazing tool for both stabilization and repigmentation. And I think it is effective in the pediatric population as well as in adults. It allows you to avoid systemic steroids. I do not use the heavy hitters in my kids. I'm just so respectful of inducing other changes. I do not use cyclosporin or the other non-steroidal immunosuppressants because I'm such a proponent of, I believe in short-term steroids if the disease is progressive and getting that patient on phototherapy. If your patient cannot come into the office for phototherapy, then certainly home phototherapy is an option. But yeah, I don't use the heavy hitters in my kids. I just don't find the need, and I don't keep them on long-term steroids for 6 months. I cited that study simply because we have limited oral mini-pulse data in the pediatric population, but no, I don't go for long periods.
Yes, any further question? Yes. Well, where do you place the role of oral JAK inhibitors in pediatric vitiligo?
I think, Devendra, that is emerging data. The first thing we have to do in the pediatric population in those kids less than 12 is get the topical approved. But I think that if we look at the future, clearly the path of the future will be getting an oral JAK approved in adults as well as a pediatric population.
Yeah, thank you. Yeah,
I think that's one of the that would be the new changing landscape as we move forward.
Yeah.
Hello, Widad Mustafa from Egypt. Please, Dr. Grimes, as long as you use systemic steroids in the small children only for 2 weeks, which formulation and what's the dose that you use, and how do you stop it?
so we will go up to, we use prednisolone. My typical patient, where I would use prednisolone, 15 milligrams per 5 cc's, and we will use either a teaspoon or a half a teaspoon at 8 o'clock in the morning for up to 2 weeks. That is my standard.
And if it doesn't work in 2 weeks?
Well, you can always, so if I'm going to give systemic steroids, that's a patient that I may also recommend narrowband. If it's not working, you can always come back and retreat. But I wouldn't consider retreating before 6 weeks.
We always use systemic steroids with narrowband from the start, but when we give them longer, we need to give them longer. We don't see patients improving in 2 weeks' time, but we usually use oral menopause, even for the small children.
Well, as I said, I think we all have our own protocols, and this is what we get amazing results in our pediatric population. And I have just always been, I use steroids, but I just tend to be steroid conservative. I like to get the kids in. Keep in mind, when we use systemic steroids, we're also using topicals to help with stabilization and repigmentation. So for me, I am conservative, and chances are, if I'm going to use systemic steroids, I'm going to really push narrowband as well, and it works for us.
Sami Aismat, Dr. Grimes, how are you? I'm Dr. Sami Aismat, yes, how are you? We are missing you here, and we're happy to have you.
I loved your paper on narrowband for stabilization in adults. I think you guys should do that in kids. I thought it was just such a great paper.
Yes, thank you. I'm just asking about your rationale by using the steroids for 2 weeks. Do you mean, can we say that we wait till the narrowband work for stabilization? For this, you can use the steroids for the first 2 weeks to start the stabilizing process, and then the narrowband continues?
You know what I do? If the patient cannot come in for narrowband immediately, but I very often will do both simultaneously. If I don't wait, I do both.
I know you do both, and you stop steroids after 2 weeks. I mean, the rationale behind the 2 weeks is that we have a rapid stabilization first with the steroids, and then the narrowband usually starts a little bit later, the stabilization.
Exactly. I
Yes.
know in your narrowband started at 2 months.
Yeah.
And so again, my rationale is I'm giving them something to immediately, hopefully, impact the immune response.
Yes.
We're giving them narrowband 2 to 3 times a week to hopefully continue to kick in to help stabilize them.
Yes. All right. Thank you. Thank you, madam.
Thank you. So, last question, yes.
Yeah. Hi, Pearl. I'm Marwa Abdullah, and I loved your presentation. Actually, we have some of the kids that do not stabilize readily. You give them the oral mini-pulse and the narrowband UVB for 3 months. They come with activity. For 6 months, they come with activity. So I'm really surprised that 2 weeks of steroids and then continuing on narrowband will get stabilization so fast.
You know, let me tell you what we do different. And I looked at how often we follow our patients very, very closely. I am so hands-on with my kids. I will see the kids every month and we take detailed photos. So I know what is happening with the kids. And even with that lower dose, my message to you is, you know, you can always retreat. And for me, if I can get that child stable with less steroids, narrowband 3 times a week, that's what I'm going to do if my close monitoring shows that they are responding. If they are not responding,
I can always go back and repeat the steroid dose because I'm
Okay.
seeing them once a month. Once I get them stable, then I'll see them less often. But to me, this is one of the nuances of how we approach the pediatric population. So for me, with oral steroids, less is more because I know that I'm so hands-on in knowing what is happening to that patient over time.
Okay, thank you very much. Yeah,
Oh.
thank you
Okay.
very much.
Thank you, Pearl, for really a awakening talk on pediatric vitiligo.